The study was conducted at Center for Ilizaro Techniques, Akola. Currently, medial open wedge high tibial osteotomy is extensively performed and researched and comprises almost 90 to 100% of the literature on high tibial osteotomies. However, patients may present with differing grades of severity of the varus. So the question is, can this single osteotomy treat all the myriad presentations of MCOA? As evident by variable deviation of the mechanical axis, the varus deformity may arise from either the proximal tibia as measured by the medial proximal tibial angle, or from the distal femur as measured by the mechanical lateral distal femoral angle, or from the knee joint itself as measured by the joint line convergence angle and the condylar plateau angle, or it may be associated with the fixed flexion deformity, a tibial torsion, or a limb length discrepancy. Our experience and measurements lead us to believe that one HTO cannot solve all these problems. For the past 30 years, we have performed 4 different types of high tibial osteotomies based on our familiarity with hardware and technique and access to knowledge. We have performed the focal dome osteotomy since 1991. It is a reverse dome osteotomy allowing correction of large deformities without reducing bony contact. It allows fine-tuning of the valgus to correct dynamic varus post-operatively. The Tomofix became available to us in 2011, and we have performed MOHTO with accuracy and reliable results, especially in patients who are reluctant to use a fixator. The tibial condylar valgus osteotomy is a L-shaped intra-articular osteotomy popular in Japan, which we have performed since 2014. It gives pain relief by improving congruent contact of the femoral and tibial condyles to increase weight-bearing area, offloading the medial compartment and correcting dynamic varus. The last is a tibial condylar valgus osteotomy with the Ilizaro fixator, which is a double-level osteotomy. The proximal intra-articular osteotomy is acutely fixed with screws and pins after correcting the intra-articular deformity. A second distal extra-articular dome osteotomy allows gradual and complete correction of mechanical axis in patients with severe varus. A large intra and extra-articular varus corrected with a double-level TCVO-I like such. There is no literature regarding specific indications for different high tibial osteotomies for medial compartment osteoarthritis of the knee. We aim to clarify the choice of different HTOs by location and severity of deformity based on extensive X-ray analysis and measurements. More than 13,500 measurements were performed on 126 patients and 141 knees by 4 observers who performed 24 measurements per knee. Radiographic assessment consisted of full-length and apilateral radiographs of the knee, and the deformities were categorized into the following. Primary deformity was a coronal plane varus measured by mechanical axis deviation, medial proximal tibial angle, mechanical lateral distal femoral angle, and hip knee ankle angle. Secondary deformity was an intra-articular deformity which was measured by the condylar plateau angle, which is measured by tangents to the broadest concave part of the tibial condyles, and the joint line convergence angle between the articular surfaces of the femur and the tibia. Tertiary deformities in the sagittal, rotational, and axial planes were measured by posterior proximal tibial angle and limb length discrepancy. We also measured joint line orientation of the knee and the ankle relative to the horizontal. Angle alpha and width omega were calculated by using the Miniachi method. The study was an analysis of consecutive HTOs performed over the last 9 years. We included patients operated for medial compartment osteoarthritis with a high tibial osteotomy who had full-length pre- and post-operative X-rays available on PACS for measurements. These were our exclusion criteria. Clinical examination consisted of eliciting tenderness in the medial and lateral compartments and documenting the range of motion. We elicited mediolateral laxity in the supine position, dynamic varus while walking, and also documented laxity under anesthesia. Fixed flexion deformity was documented only clinically, and torsion was documented only clinically. We did not use CT scans for determining rotational problems. Intra-class correlation coefficient was calculated to compute inter-observer reliability between 4 sets of measurements. Telephonic interviews were conducted to assess WOMAC scores post-operatively. The subjects were divided into 4 groups. MOHTO consisting of 58 knees, as in this pathologist with a mild varus deformity. The FDO-I consisting of 40 knees, as in this one with a moderate varus and significant tibial intorsion. The TCVO-P consisting of 26 knees, as in this lady with moderate varus and pagoda tibia due to a high condylar plateau angle. And TCVO-I consisting of 17 knees, as in this 58-year-old gentleman with severe varus, large CPA and JLCA, and a tibial intorsion. These were the statistical methods applied. The mean age of our patients was 56.3 years with a standard deviation of 9.2. Average follow-up was 44.6 months. This is the distribution of sex and distribution of laterality. KL grade 3 and 4 constituted 80% of the knees, but these patients had no lateral joint line tenderness. All patients with higher KL grades were advised total knee arthroplasty by many surgeons, but patients insisted on a high tibial osteotomy. Our mind was open to the utility of HTO even in higher grades of osteoarthritis like this article from AJSM. Then patients fell into 2 equal groups of 70 knees with a mechanical axis deviation greater than or equal to 0% and 71 knees with a MAD of less than 0%. There was a strong correlation between MAD of less than 0% and the presence of an intra-articular deformity. The mean preoperative MAD, which is marked in red for each group, corrected to the Fujisawa point in all except the TCVOP, which was slightly undercorrected at 45.2%. The range of correction of mechanical axis deviation was the maximum in TCVO-I, followed by FDO-I, then the TCVOP, and least in MO-HTO. There was a statistically significant improvement in MAD, HKA, and MPT after surgery, while the PPTA remained unchanged, indicating that there was no inadvertent alteration of the tibial slope. The knees with the highest condylar plateau angle were treated with the TCVO-I. The CPA was unchanged in the extra-articular osteotomies, while it improved significantly in the intra-articular group. And there was a significantly greater reduction in the JLCA in the intra-articular osteotomies. The change of JLCA in extra-articular osteotomies is explained by the coronal hypomocleon, where the tipping point is 2 degrees of hip-knee ankle angle. The knee joint line orientation was altered least in TCVOP. The intra-articular osteotomies resulted in lesser oblique joint lines. Similarly, the ankle joint line orientation was altered least by TCVOP, allowing the ankle to remain parallel to the ground. There was a strong to almost perfect correlation between interclass correlation coefficient between 4 sets of measurements. The mean WOMAC score was 9.8 with no significant difference between osteotomies. Complications of MO-HTO consisted of Takeuchi type 2 and 3 hinge fractures in the larger corrections. Of FDO-I included overcorrection in 13 patients, which was performed to overcome dynamic varus. TCVOP had 2 deep infections after union, and TCVO-I had 2 cases with fractures. MO-HTO is ideal for correction of mild varus deformities, but it may not be suitable for severe deformities. Opening a large wedge in severe deformities may lead to lateral hinge fractures, ACL degradation, alteration of patellar height, and cartilage damage. Had we performed an MO-HTO for the other groups, a much larger 17.7 degree opening angle needing a 19 mm wedge definitely would have led to complications. Thus, MO-HTO is ideal for a mild varus without any associated intra-articular and tertiary deformities. The FDO-I allows safer correction of larger deformities and can tackle deformities in sagittal, rotational, and axial planes. We overcorrected the varus in many patients with FDO-I to compensate for dynamic varus. Though the dynamic varus was eliminated, it led to some obliquity of the knee and the ankle joint lines. Before 2014, 22 FDO-I surgeries were performed for patients with a large intra-articular deformity measured by CPA. Henceforth, such patients will definitely get an intra-articular osteotomy. Moderate to severe, thus FDO-I is ideal for moderate to severe varus without any associated intra-articular deformities, but can tackle tertiary deformities. Since many of the moderate to severe varus deformities are accompanied by intra-articular deformities, the FDO-I is likely to see lesser use in the future. Although the TCVOP modestly corrected MAD, it adequately corrected the intra-articular deformities and did not overcorrect MPTA, AJLO, and KJLO, and thus it deserves to be performed much more. Hence, the TCVOP is ideal for a moderate varus with associated intra-articular deformities, but cannot correct tertiary deformities. Though we slightly undercorrected the mechanical axis deviation, basis of pain relief in this surgery is attaining simultaneous congruent contact of both the tibial and femoral condyles. To address the undercorrection, we performed an additional distal osteotomy in a final 4th group of 17 patients, which adequately corrected the most severe varus deformities, corrected the intra-articular deformities measured by CPA and JLCA, and also helped to correct the tertiary deformities. Thus, the TCVO-I is ideal for severe deformities in all the 3 categories. The results of our intra-articular osteotomy are comparable with literature. The limitations of our study are that it is retrospective with unequal groups, and we could obtain only post-operative WOMAC scores in 84 of the 126 patients. To conclude, the choice of osteotomy depends on the location and severity of the deformity. The primary deformity, which is a varus deformity, which can be mild with a mechanical axis deviation of greater than 0%, moderate with a mechanical axis deviation of 0 to minus 25%, and severe with a mechanical axis deviation of less than minus 25%. The secondary deformity is an intra-articular deformity which is characterized by the presence or absence of an abnormal CPA and a JLCA. The tertiary deformities are in the sagittal, rotational, and axial planes, which may or may not be present in the patient. To summarize, based on our extensive measurements and analysis, I conclude that a MO-HTO is ideal for mild varus without any associated deformities in the secondary and tertiary categories. The FDO-I is ideal for moderate to severe varus deformities, but cannot treat associated intra-articular deformities and can tackle tertiary deformities. The TCVOP is ideal for moderate varus with associated intra-articular deformities, but does not tackle tertiary deformities, and the TCVO-I can be reserved for the most severe deformities in all the 3 categories. Thank you.